All right, next up is Dr. Avrum Joffe coming to us from Bergen County. Does a lot of stuff out of the Valley Hospital, but recently got some privileges here to help us out. So he's going to talk about when things go pop. So knee injuries in the young child.
Hi. How's everybody doing? I'm actually doubly excited to be here because my first cousin, who's in the back, Dr. Abby Grossman, is a pediatrician who, for the first time, I'm in the same room professionally with her, even though she lives literally 3 blocks from me. We have never interacted in a professional manner. She's probably going to give me a bad review, which is fine. So thanks very much for having me, Ellen and Jim. I really appreciate it. So I'm going to talk about when things go pop in the knee. And just to give you some statistics, this is from a study a couple of years ago, so I'm sure the numbers have increased since then. 30 million athletes, student athletes between the ages of 6 and 21. 7.2 of those are in high school. And look at these numbers of injuries in the hundreds of thousands. Football for ages 5 to 14 and basketball for ages 15 to 24. And again, I'm sure these are shifting. It always surprised me to see the baseball injuries 0 to 4. I'm not sure who's able to play a real competitive baseball game at age 3, but that's fine. So severe injuries, which is classified as losing participation for up to 3 weeks, or requiring surgery. That counts for 15% of all these, and the most frequent is the knee by far. There's a predilection towards female athletes, and again, the statistics there, knee is 30%, and a sharp drop off to ankle and shoulder. As Dr. Friedman touched on before me, so I won't harp on any of this stuff, there's obviously health benefits that outweigh the risks associated with sports participation. Obviously, weight management's number one. It's much better than being sedentary and having diabetes or anything metabolic like that. We have increased strength, improved flexibility, increased conditioning and endurance, and of course, self-esteem is a huge one. Again, as Dr. Friedman mentioned, prevention is really number one. It is so far lagging behind the treatment. Our technology always gets better. We can do ACLs better than we could 10 years ago. We can do MPFLs better than we could 10 years ago, but we don't really do much. And once in a while, me and my colleagues, give lectures to physical therapists and to athletic trainers and get a lot of blank stares when we talk about stretching and preventative programs. So we really have to do better about emphasizing that. One thing one of my professors in fellowship used to say is that physical therapy is an activity, not a location. It's not some place you go just to hang out. So actually doing it, really important. Again, I won't harp on any of that stuff. All right, so anterior knee pain and the patellofemoral joint is a common place of patients sensing a pop or friction of some kind. You can hear it referenced as just patellofemoral joint pain, chondromalacia patella, where the cartilage surface is between the, there we go, where is it? Between the trochlea and the patellar undersurface are creating a friction. Usually it's from maltracking, as you see in the picture below. You get that lateral patellar tilt that you can see on an x-ray. Most kids with this will point to pain and popping in the superolateral aspect. Some will say popping, some will say achy, and they feel stiff when they get up after sitting for a long time. They sometimes mention a catching or giving out episode. Usually there's no swelling, not much in the way of dysfunction. They're still carrying out their soccer, they're still participating in all their activities. Their range of motion is good. Moving their patella around usually aggravates it. No effusion, again. Always make sure the hips are okay. I'm sure that was touched on before I came up here as well. Most of these kids you find have tight hamstrings and quads on examination. The typical test maneuvers are above, detecting someone's popliteal angle by flexing their hip up to 90 and stretching their leg, and a prone examination. When you're doing this prone examination, you want to make sure that their pelvis isn't coming off the table, so you always want to do this on a flat examination table because that's a cheat. No need to get MRIs for these patients. A lot of us are goaded into it by parents, myself included. I'm not immune from that. But there's really no traumatic event. There's no reason to get an MRI. Again, activity modifications, NSAIDs, ice and heat, stretching and strengthening. If you need to get them out of activities, rehab is a great thing to do. Gives them something to occupy their time and get their pain better. and these almost always get better with the conservative measures of treatment. Again, just some proper stretching techniques. So getting on to more acute injuries. This was a great study that was done about 6-7 years ago, looking at MRI findings. These guys did a study on all patients that came in with a fusion or a traumatic hemarthrosis. So ages 10 to 18, their examination was limited due to the effusion, and it was done to kind of stratify which injuries were being seen more commonly. Patellofemoral and ACL injuries were the most commonly found things, and these were associated with having negative x-rays. Now, 41% of these patients underwent surgery, so that's a high percentage, and that speaks to why MRI is important for these patients with traumatic hemarthrosis. We'll touch on anterior cruciate ligament tears first. All of us have seen the recent dramatic increase. When I was in residency, which is only 10 years ago, this was an injury for age 19 and up. And when I came out of fellowship, I thought I'd be doing only a handful of these. It's one of the more common outpatient procedures we find ourselves doing now. Again, as Dr. Friedman mentioned, there's increased athletic involvement, lack of diversity in sports participation, multiple teams during one season. We could have lots of debate about all that stuff. It's frequently seen as a non-contact injury, twisting, you felt a pop. Pivot shift is the typical description. You go to pivot, your knee goes one way, you go the other. There's usually an immediate large effusion or hemarthrosis. And as you see the statistics from that study, 47% of pre-adolescents with a traumatic knee effusion will have an ACL injury. And I'm sorry, the Lachman test, which is where you flex their knee slightly and try to draw the tibia forward. We always get an x-ray, but MRI, again, confirms the diagnosis. It also lets us look for concomitant injuries, which is frequent. 50 to 60% of people with an ACL tear will have some kind of meniscal injury. That also helps us for preoperative planning. Non-operative treatment for ACL injuries, even in the very young and very immature, not good. We know that all the giving out of the knee, no matter how much rehab you do, they're eventually going to wear down the cartilage surfaces. They're going to get more meniscal tears as they go forward. So we used to try to say, brace these kids, do PT until we can get them through to maturity. Because of the damage that can be done, from our perspective, it almost seems better to do the surgery, and if, God forbid, you have to do it again once they're skeletally mature or 18, so be it. At least you prevented the secondary cartilage loss and damage. And sorry to go back, open physes, not to harp on the surgical part of it, you got to be careful with how we do fixation. That's more for us to worry about. Tibial spine fractures is the bony equivalent of an ACL injury. Same thing, you'll feel a pop. It's more common in kids under age 14, where the ACL inserts onto the tibial spine. They actually get a bony avulsion. If it's not very displaced, it's actually a better outcome. Obviously, look for the laxity just as you would for an ACL injury. Just a note about the Lachman test, don't be fooled into being sure there's an ACL injury, because a lot of kids do have baseline laxity before getting close to skeletal maturity. You'll usually see this on a radiograph pretty readily. MRI is pretty much useless. CT scan can help you with quantifying the amount of displacement. Depending on what you read, people will say 0.5 centimeter to 1 centimeter of displacement is acceptable. And these kids will do fairly well. About 20 to 30% of them will have ongoing laxity because of the stretch of the ACL fibers that went along with the injury. Again, that's something you can cross once they're done with the healing process. This is something we can fix open, arthroscopic. There's no real difference in outcomes doing it either way. Again, it's just about being mindful of the after effects of laxity. On to patella dislocations, commonly occurs in the ages 14 and up. From acute traumatic, we'll talk about chronic in a second. High-level adolescent athletes, again, same kind of mechanism. Indirect force applied to the planted lower extremity. Usually the knee is partially flexed and buckling into a valgus position, so knee buckling inward. It can be a little deceptive, and it's a very similar mechanism to ACL. I have certainly been fooled, and kids don't always give you the best history. I think my colleagues would agree that they've been fooled before. They'll say, oh, my kneecap went out, but really it was their tibia shifting forward when they felt it. and their knee just seems loose all around from the effusion. So again, that's why the MRI is so helpful. Non-contact injury, usually the kneecap pops into place on its own because the kid will fall to the ground and extend their knee. Just as with an ACL, they get rapid onset of swelling. If you have to reduce it, you just do gentle passive extension and medial pressure on the kneecap, and usually it pops right back in. Occasionally I've had to sedate a wild patient for it, but usually you can do it without it. And again, always do your Lockman test afterwards to assess for any ACL injury. Imaging these, this sunrise or merchant view is the most telling. You can see how the kneecap is off track laterally. Tells you that the medial patellofemoral ligament, which stabilizes your extensor mechanism, has been disrupted by the dislocation. There has been a big push in the last 5 to 10 years to be more aggressive with first-time dislocators, but most of us agree on non-operative treatment first time around. I certainly try to avoid it unless there's a bad osteochondral injury going along with it. Just showing you here on the radiograph, there's an effusion present. That's that cloudy pocket beneath the quad tendon. And in this particular patient, I don't know if you can see there's kind of a white sliver. I'm not sure if that's projecting well. That would be an osteochondral injury. So this particular patient had a fracture off one of the facets of the patella. Up to 20 to 50% redislocation rate reported. I don't think I even see 20% clinically in my practice. I think the rate's 20% or lower. But again, we quote those studies to try to scare people, I guess. Conservative measures for the first-time dislocators, knee immobilizer for 3 weeks, and then we start PT. Doing the PT in this situation is of the utmost importance. Build up quad strength, try to stabilize that extensor mechanism. We work on stabilizing the vastus medialis branch of the quad to really try to keep your kneecap pulling medially and keep it on track. So when there's a loose osteochondral fracture or any other major injury, we do recommend arthroscopic procedures to remove it. And for recurrent dislocators, we can reconstruct the ACL, the MPFL. Certain anatomic factors to consider, which I won't harp on, are rotation of the femur, that's femoral anteversion, tibial tubercle trochanter distance, and how dysplastic their trochlea may be. Just to show you an example of that before I talk about chronic. So someone in this situation, you see the trochlea is very hypoplastic. There's almost no groove for the kneecap to sit in, so it's no shock that this person's a chronic dislocator. So just a note about chronic patellofemoral instability. A lot of these are from early juvenile years. Even I see them as young as age 4 and 5. A couple conditions such as Down syndrome or anything where there's loose ligaments or ligamental laxity, you're going to see it more commonly. Again, femoral anteversion and anatomic factors contribute to this. They often come in with quadricep weakness from how many times their extensor mechanism has given out. They have genuvalgum. They're generally loose in other people if you're looking for how much their fingers hyperextend or their elbows hyperextend. 85% of these patients have some kind of trochlear dysplasia, not all this severe, obviously. And you'll find them to be very loose on examining their kneecap in the supine position. Meniscal tears. Isolated tears are not commonly seen. Again, it's usually along with an ACL injury, as we talked about earlier, but it does happen. You'll see it more in the late teenagers as they become more adult. It's usually a twisting injury. There's joint line tenderness and pain. They have swelling and effusion. The subjective description of locking and giving out, less important in this population. There's a lot of proprioceptive nerve fibers in the horns of the meniscus, and so it can give you that sensation without really being, frankly, unstable. And then there's the, there it goes. The tests being shown to you here, the McMurray and the Apley compression test, basically compressing the knee in flexion and rotating it. That's a pretty specific test to do. You always do the x-rays to rule out other injuries, such as a fracture or osteochondral injury. I myself have mistaken a femoral osteochondral subchondral fracture for a lateral meniscal tear on physical exam. That's why the MRI is so important. And you see the nice triangle of the meniscus here. Is that showing up my arrow? No, it's not. And then in the back, posterior meniscus, you'll see the cleft where it is detached. Oh, there's a pointer? I'm sorry. Hey, look at that. So the nice intact triangle here, and again, the cleft from where the meniscus has torn from its root and capsular attachment. All right. For meniscal tears, treatment is arthroscopic debridement if it's an inner tear versus repair when it's a more peripheral tear. In our textbooks, it says 50 to 90% of meniscal tears in children are amenable to repair. I think I disagree with that, and I think my colleagues would too. The very peripheral tears and root tears certainly are. Radial tears, or inner tears rather, are very poor rates of healing with repair. They do better when there's ACL reconstruction along with it. The belief is that there's more blood flow and more vascularity and more basically iatrogenic trauma to the knee when you're reconstructing the ACL, which brings those healing factors to it and helps you heal. Meniscus injuries, not great long term. There's increased joint contact forces, and that's even been shown with repairs, just having had the injury itself. There's a study that's well quoted in adult literature that patients had sham surgery where they just put the arthroscopic camera in the knee joint and then took it out, and then some actually had their meniscus tears treated, and there was no difference in long-term outcome. So that, no reason to do it for arthritic knees. So long-term, again, it increases these joint contact forces because you lose that cushion, and even when you repair it, you lose that function of that absorbing cushion. So I don't think the long-term data on that's going to be great. This was already touched upon, so I'll go through this briefly with osteochondritis dissecans lesion. Typically when they become unstable is when the pop is felt. There's this weakness in the subchondral bone that allows a piece of cartilage to break off. As Dr. Friedman mentioned, surgery is indicated for the acutely unstable injuries or chronically unstable injuries. These are very unreliable to examine just by physical examination alone, so x-rays and MRI are of the utmost importance for those. All right. So we try to do non-surgical treatment for the stable lesions rather, and again, it can be a long time of conservative measures, which can be very frustrating for people. And then treatment with either by drilling, pinning, putting screws in, whatever you have to do to get it stable. One other thing I'll touch on, which can create the popping knee, is actually a normal structure, which is called your synovial plica. I say that it's a normal structure because more than 60% of the population has one. It's like a ligamentous or embryologic remnant that glides over the medial femoral condyle here, so that creation of friction as you move your knee creates that snapping or popping. Primary tears are rarely seen, but it does happen. Usually it's from repetitive activity or trauma, things where kids are jumping or kneeling a lot, like rugby players. Oops. Kids will often say they have a catching or giving out sensation. Usually you can feel it on physical examination. Radiographs are normal. You can find it on MRI. You might see some friction and some edema in that medial femoral cartilage, but not always. Usually this does very well with the conservative measures of treatment, the usual rest ice, elevation, compression, activity modification. You can resect it arthroscopically if it's absolutely necessary, and they've failed months and months of conservative treatment, and people are happy after that. Some people just get very pathologically thick there, and it just drives them nuts. I put this in just the other day because of I don't know if anyone saw this on the headlines on CNN about Dr. Sanjay Gupta telling us how bad steroid injections are. We kind of already knew that. Not great for older people with osteoarthritis. It seems to, after many injections, accelerate that wear down of the cartilage. So not great long term. Probably doing it once or twice for a bursitis. Not too bad. Uh-oh, what did I do? Sorry. There we go. Nope. Anywho, that was the last slide. Low threshold for MRI when there is immediate onset pain and hemarthrosis. Oh, it didn't come up, did it? There you go. Thanks. Having a low threshold for MRI when there's hemarthrosis again. Conservative measures for any other injury. And again, we can do better with regards to injury prevention. Thanks so much.